Good evening, everyone, and welcome to tonight's panel. I am your host, Joyce Jose, and I'm going to be walking you through a very important discussion on tonight's panel, and we're talking about the developing eye and what to expect. We are fortunate to have with us two distinguished experts in pediatric eye care. That is Dr. Josephine Ibironke, a leading pediatric optometrist, and Dr. Ann Arthur, a renowned pediatric ophthalmologist. Before we go into our discussion, I would like for us to take a moment and do full introductions because these women have done profound things and continue to do profound things in the field of eye care. So, first, daughter of Grenadian immigrants, Dr. Ann Arthur was born and raised in Brooklyn, New York. She obtained a bachelor's degree in political science from Brown University before earning her medical degree at Yale. She then completed her internship at St. Vincent's Medical Center in New York City, her residency in the Department of Ophthalmology at Case Western Reserve University in Cleveland, and her fellowship in pediatric ophthalmology at Willis Eye Hospital in Philadelphia. Dr. Arthur is currently the owner of the private practice Park Slope Eye Care Associates in Brooklyn, New York, and performs surgical procedures at the New York Eye and Ear Infirmary of Mount Sinai. In addition to volunteering as a teacher and physician in the United States and abroad, she has established and acted as a founding board member for the multiple student scholarships, co-chaired diversity and community engagement committees, served on the NYS Board for Professional Medical Conduct, and held the role of PTA president for PS11 in Brooklyn. Her passion is working at the intersection of healthcare, advocacy, equity, education, philanthropy, and community building. Dr. Arthur is the inaugural director of alumni engagement at the Yale School of Medicine. Let's welcome Dr. Arthur.
Thank you.
No, thank you. And now, Dr. Josephine Ibironke. Dr. Ibironke is a professor and the Associate Dean for Professional Engagement at the Kentucky College of Optometry. In her role, she teaches pediatric-related courses, serves pediatric patients, and oversees the professional development of students. She helped develop the KYCO Vision Screening Initiative to provide screenings for all third grade students in Pike County, Kentucky, to help fulfill the state-mandated requirement for screenings. She also developed the pre-optometry summer camp that exposes pre-health students to optometry. Previously, she was an assistant professor of ophthalmology at the Wilmer Eye Institute at the Johns Hopkins University School of Medicine in Baltimore, Maryland, for 12 years. Dr. Ibironke earned her Doctor of Optometry and completed her residency training in pediatric optometry at the Pennsylvania College of Optometry. She earned a Master of Public Health at the Johns Hopkins Bloomberg School of Public Health, and she is a Fellow of the American Academy of Optometry, a Presidential Leadership Scholar, PLS, and serves on the Advisory Board of Women in Optometry. Let's also welcome Dr. Ibironke.
Thank you.
Thank you both so much for being on tonight's panel. We are so excited to have this discussion. And those of you in the audience, welcome. This is very much a discussion. Let us know where you're tuning in from and what questions that you may have. If you are lucky, we'll be able to get to your questions, but this is a discussion and we want you to fully engage. So back to the topic, as parents, caregivers, and educators, ensuring the healthy development of a child's vision is crucial. Yet, it's an area that's often overlooked. Tonight, we'll delve into the fascinating journey of how vision develops from infancy through childhood, the importance of early detection and routine eye exams, and the impact of environmental and genetic factors on our children's eye health. We'll also address disparities in access to eye care and discuss how we can all play a part in advocating for better vision health for every child. So, without further ado, let's get into it. Dr. Arthur and Dr. Ibironke, before we get into questions, I want to clear things up for the audience. We have a pediatric optometrist and a pediatric ophthalmologist here. Tell us about the eye care providers and perhaps tell us about the difference if you can.
Sure, I can go first. So thank you so much for this forum, and thank you for having us here. So as a pediatric optometrist, the training is what's different. So after college, did 4 years of college and then went to optometry school. And then after optometry school for 4 years, I decided to do another advanced training year in pediatric optometry to just allow me to better be able to take care of kids. And with that as well, the optometrist is like the gateway. I like to say the gateway, the primary care eye care provider, that we're able to diagnose and manage diseases. But if there's anything like tertiary care, so instance, if I'm seeing my kids in clinic and my kid that I'm seeing needs surgery for their muscles are not aligned, I will now refer to my colleague, Dr. Arthur.
I like that, the gateway, because you are probably like the first line soldier, if you will, or the one that we most readily access when we're going to routine eye exams.
That is correct.
Dr. Arthur, can you better clarify your role in what we call layman's terms?
Well, once again, I think the training is a little different. I, after college, went to medical schools. I have a medical degree, a doctorate of medicine. And so I'm a physician as well as a surgeon. After completing medical school, you do an internship where you're seeing people with various diseases. So you might spend a month in pediatrics, a month in surgery, a month in OBGYN, a month in internal medicine. So you're sort of getting broad-based education about healthcare. From then, we do a 3-year residency training program where we're taking care of patients, Monday through sometimes weekends, also round the clock, essentially, and learning our craft in terms of diagnosing as well as surgical treatment of eye diseases. And then because I was interested in strabismus and interested in pediatric eye health, I did what's called a fellowship. So I did an extra year of training so that I have subspecialty training in pediatric ophthalmology. So once again, working with optometry to enhance the health of children's vision, but also sort of taking it to the other point of if there needs to be surgical management, that's what I'm trained to do.
Yeah.
Okay, so a difference in training, different specialties, but both have fundamental and critical understanding about the eye, how it works, things to look out for. Both of you are well equipped, it sounds like. So hopefully that provides some clarity to you all who are listening. I know it helps me a great deal as I am a person with astigmatism who sees an eye doctor multiple times a year. So it's always helpful to me to hear those differences. So tonight is all things pediatrics. You both have a background in pediatrics, and that has to do with children, with kids. And it's so critical for us as parents, or for me, an example, expecting parents. I'm learning more and more about children and development and their eyes. Something I did not know is that children are born without being able to see certain things or recognize certain colors. So, Dr. Ibironke, can you tell us about how much vision children are born with and how vision actually develops throughout childhood?
Sure, I can definitely do that. So between birth, and I'll kind of do them in stages. So between birth and 1 month, so what they see, it's not clear. It's not 100% clear. However, they do see figures and they're mostly interested in what's closer to them. So they're mostly interested in things that are probably about 8 inches to about 15 inches away from their face. Um, they're they're going to be a little sensitive to light, maybe to begin with. That doesn't mean that they can't perceive a brightly colored object that's a little bit further than that 15 inches. They can, but it's not as clear as it could be. And then let's take between 2 and 4 months. Our babies at that particular age, what they're doing right now is they're starting to pay more attention. They're starting to track a little bit better, so that when they're looking at somebody moving or an object moving or target moving, they're actually able to track a little bit better. It's probably not going to be a nice, smooth track. It may be a little bit inaccurate until it gets to where it's getting to, but by 4 months, it should be accurate enough. Also, in that time is when they're looking at their hands. So closer to about 4 months, they start looking at their hands, start seeing where they are in space. Of course, this is also probably when they're teething, so they're probably holding on to things and shoving it in their mouth. And then, of course, looking at their caregiver happens right about now. And then at about 5 months, and I know Dr. Arthur and I, we this is 100%. The eyes should be fully aligned by 5 months. There shouldn't be any kind of roving or eye misalignment by 5 months. So if when they're born till about 4 or 5 months, the eyes could be roving a little bit where one eye kind of looks like it's a little cocked and a little crooked. It should not be that way anymore after 5 months. And then 5, 6 months is where they see depth. So they know where they are in space. They start to refine that and they can engage. They smile, they see you. And then about 9 to about 12 months, they're already on the go anyway, right? So they're trying to get from point A to point B, crawling, walking, so they are able to see a little bit more at a distance. Preschool age, so their focusing is now in play. They're learning to read or identifying shapes. So focusing, depth perception is getting more refined at that point as well. And then now let's talk school age children. These children, they're likely to become more nearsighted as they're growing. So those of you in the audience, if you have a grandkid or you have a child and they never wore glasses at 7th grade and now all of a sudden they're in the 9th grade and they need glasses, it's probably because they've progressed into nearsightedness and now they need glasses.
Interesting. And this is why it's so important to be up to date with your pediatrician visits
Absolutely.
and your optometry visits, because the eyes are developing at every stage. I did not know that the stages were so profound in development. I do know that a lot of my friends are gifting me baby books that are black and white.
Right.
Colors.
They like the contrast.
Yep.
Interesting, like high contrast. So it's not that they cannot see colors, it's that they can better appreciate high contrast as newborns.
Right.
I appreciate that. Dr. Arthur, so knowledge is power, and it may help some parents feel better when they're thinking of routine visits to their pediatrician. What is a pediatrician looking for at an eye visit or when a child is visiting in terms of ocular health?
Well, for newborns, the pediatrician is doing a couple of things. The pediatrician is looking for any sort of external disease, any droopy lids, any missing or skin tags around the eyes. They're also looking to assess the ocular alignment. They want to make sure the eyes are straight. If it's an infant above the age of 6 weeks, they want to make sure they're responding to a face, a smile, which is one of the first things that you will notice if a child can see. They're looking for the red reflex. I don't know if you've ever used one of the old-fashioned cameras. Back in the olden days, we had the film cameras, and we would see a little red reflex coming back when we tried to take a picture. Well, that red reflex is something that the pediatrician is looking for, your primary care provider is looking for, because that red reflex gives us an idea that the ocular media is healthy. So believe it or not, babies can have cataracts or other problems that affect that red reflex. So if they don't see that red reflex, that's an automatic referral to either a pediatric optometrist or a pediatric ophthalmologist.
And nothing to be afraid of. I imagine that the earlier you can catch these things, the better the child's outcome and the better
Exactly.
resources available.
Exactly. And children who are a little older, they sometimes will use a little bit more sophisticated methods to evaluate them. So you might use something that looks almost like a camera, and that can assess a different reflex and give them an idea if this is a child who might need glasses, even if the child does not read the eye chart, or it's a child that might have a misalignment of the eyes. And then older children are getting a vision screen. They're reading the eye chart, and someone's looking to see if they're 20/20 at a particular distance.
Dr. Ibaronke, what is the difference between a vision screening that a child would get at a childcare program or in school and a comprehensive eye exam?
Yeah, so there's actually a huge difference to that. One of the reasons is who's doing the screening, right, at these childcare facilities. So some of the time it's a nurse, and we appreciate the fact that they are doing the screenings because at least they're looking for gross abnormalities. The problem though is that they're not able to diagnose right there. And then not only that, they're also not able to do the management, like, hey, this is what we need to do. Also, in the United States, we don't have a standard for screenings that's done at these school facilities or these childcare facilities. I know Prevent Blindness has certifications out there, but not all these screeners are training and getting that certification. So it's very hard to have one childcare place is doing screenings a certain way, another one's doing it a certain way. We don't have a standard for it. Again, it's quick, it's easy, we like it because at least it gives us like, hey, something may be wrong with this kid, but it's not going to diagnose. And then in terms of that comprehensive eye examination, of course, that's something that myself or Dr. Arthur will be doing. That's where we look at the kid and we do the entire evaluation. So we put the drops in the eyes. I know everybody doesn't like to hear the drops, but we put the drops in the eyes. We're able to look for eye diseases, front and back of the eyes. We're also able to tell if a kid needs glasses or not. We're able to look at their tracking and their eye alignment, making sure that the eyes are completely aligned. So those are the differences there between the two. Again, we love that we're having some kind of screening done, but it's the comprehensive eye exam that's the ultimate.
Great. So I'm hearing screenings are important, but they're not the same across the country. So it's great that your child gets screenings at their school or their program, but they, one, are not standardized and they cannot diagnose your child with anything. A comprehensive eye exam will allow there to be a diagnosis, which means you can get your child support and help early on with all the resources and information that you can. Okay, so what if I'm a parent and I'm hearing all this, Dr. Arthur, and it's all, or Dr. Ibironke, and it's all well and good. I believe you, but I don't wear glasses. My husband doesn't wear glasses. Is it really that important that my child get an eye exam? Why is it important that my child get an eye exam?
Well, I work in an urban area, and I can tell you that all those really rare things that I learned in medical school and residency and fellowship, I see them. So I have seen babies with cataracts and babies with glaucoma. I've diagnosed kids with brain tumors. I've found all sorts of very interesting things doing a comprehensive eye exam. And so for me, I always try to emphasize with people that it's not necessarily something you have to do every year or every 6 months, but if there's anything abnormal, you really, sometimes these are the precursors for other systemic diseases or neurological conditions or brain conditions, and the eye is how we're picking all of this up. So I would say that if you are being referred by, a school nurse or a pediatrician who did a screening, it really sort of behooves you to follow through on it and just to get an idea of what your kid's status is. And once again, I can tell you stories. I've been in practice 29 years, and I've seen probably almost every single textbook thing that I've learned and in school. And it's frightening how sometimes it can be very subtle, particularly when it's your kid. I've had people come in, walk into my office, and they haven't even sat down, and I go, your kid has glaucoma, right? And I'm thinking they're there for a second opinion and they're just coming in to be seen. Um, or I'll say, oh,
You can
wow.
see
No,
just by looking at the child.
sometimes you can. They walk in and you can tell them as Dr. Ibraneke is nodding her head because she's probably had the same experience where there's some physical signs. They walk in and you can see it. I've had kids walk in and I'll say, the eye is bulging. And the
Yeah.
parent will say, what? And I'm like, yeah, come look, stand where I'm standing and look at the face. And they'll say, I didn't notice. And I said, well, you see the kid every day, right? And I'm seeing him for the first time. And with pediatrics, we have to take in a lot of information very quickly because kids start getting tired or they're scared or they're crying or they don't understand. So there's a lot of what we pick up is really looking at the kid, not even touching them, necessarily immediately, and picking up a lot of signs and symptoms. So I would tend to tell people to err on the side if you have access to a pediatric eye care provider and you've been referred, probably behooves you to follow up on it.
And also the learning. So the learning, if a kid has something and we don't pick it up, it affects their development. It affects their learning. So just yesterday, so I'm here in my office and I'm pointing that way because the clinic's that way. But one of our peds resident, he brought up a case where it was a 9-year-old that had farsightedness that had been corrected, but then compliance wasn't good with the correction, which is glasses, but it was a high prescription. We know just by hearing the prescription that that kid, now 9, should be in the 4th grade or 5th grade. Clearly, if they didn't have the glasses like they were supposed to, school probably suffered, and it's probably suffering right now. It probably suffered when they were younger, when they were learning to read, and now that he's reading to learn, it's probably suffering even more because there was no compliance to correction. That's why it's really important for that comprehensive eye examination, especially if they fail a screening and you've been referred. It's very important to follow through.
Right, I can't underscore this more. In my hypothetical, it was two parents who don't wear glasses, but I have worn glasses my entire life. My dad wore glasses, my mom had great vision. And I loved learning and I loved school, but there was a time where I was sitting in the front of class. And it was because I couldn't see the school, the blackboard. So I had to sit in the front. But what if I didn't like learning? And I just resigned myself to sitting in the back and just thought, oh, school wasn't for me. So I found workarounds before I was given glasses and prescribed or given a prescription. But not every student is that way. So Dr. Arthur was talking about the rare diseases, and you're looking at your child and saying, well, they don't have bulging eyes, and I'm pretty sure it's not glaucoma. Even in my case, where my vision is not the best, but it's not a rare textbook disease, it still inhibited my learning. And I'll never forget getting glasses and looking at my friend's hair and thinking, I can see the individual strands of your hair. Whereas before, it was just a blur, or I would learn to identify people by the way that they moved or the way that they walked because I couldn't see their face down the hall.
Right.
So if anything, if for nothing else, just think about your child is at a critical stage where they're gaining so much information at school that it's going to be foundational to their learning and to the rest of their lives. So we should really be taking these comprehensive eye exams seriously. Again, knowledge and information is power. This is not to scare you, it's only to empower you. And why not give your child the best possible outcomes by being informed, by seeing well-educated professionals who are on your child's side and just want to help. I appreciate that background information and how common it could be and how critical it could be if overlooked. I want to now talk to both of you about how we want to take eye care or make eye care a priority for families. Can both of you talk about disparities in access to eye care, specifically for African American families and children, or disparities in vision conditions? I know it's a lot, so maybe we can talk first about disparities in eye care for African American families.
Well, I think the biggest disparity that we suffer from is really a workforce issue where we don't have access to eye care professionals. I mean, probably 90% of the counties in the United States don't have a pediatric ophthalmologist. They tend to be clustered in high density urban areas. That's the first thing. The other thing is that I hope I'm getting this number right, but I don't know what it is for optometry, but for ophthalmology, probably 5% of the ophthalmologists who are practicing in this country are African American. So we don't even have people who are in these surgical and medical subspecialties who studies have shown, it's not anecdotal, they tend to work in underserved communities. And there's a direct linkage between having people who are underrepresented in medicine and care that happens in communities that are underrepresented, even if they're not communities of color per se. Most folks who are people of color who are in medicine are servicing patients who need the greatest care. So I think the biggest issue for us is really a workforce issue. Many of my patients, if you're pediatric patients, are covered by Medicaid, which is a federal program that covers folks who are below the federal poverty line. There's lots of issues with access because sometimes people don't take Medicaid or take Medicaid sponsored plans. And so that's would be the other issue in terms of having access to private insurance or being a self-pay patient.
Yeah. And that's so true. That number, that 5% for ophthalmology is the same for optometry. It's 3%.
Okay.
So only 3% of optometrists are African American or minorities. So that's huge. And also, so I live in Pikeville, Kentucky. This is a rural area. So we also have the barriers that are now causing the disparity as well. So the lack of the information, which is why this forum tonight is absolutely amazing, having grandparents and parents on here, just so you can share, so we can share this information and you can have more knowledge, because sometimes not having that understanding, that knowledge of what to do, that could be a barrier. And then also the follow through is also a barrier where, hey, my kid did have a screening. I did get a report saying that they need help, but then no follow through. So that could also lead to some of this, some of the disparities that we see, but then it is a barrier that's leading to that.
Fascinating. I've never heard of the disparity in terms of it being a workforce issue. I had no idea that the numbers were so low for both of your subspecialties. It's shocking. It shouldn't be. As an attorney, I know the numbers are low in my field as well. I also, though, know that for service providers such as yourselves, representation matters, especially in this country where there's a history of mistrust of medical professionals for valid reasons. It is so important, I know, for many people to be linked with someone that they feel like they can trust, that they feel like they have a shared history or shared understanding. It does not mean that in order to be serviced, it must be a Black healthcare professional. We're just giving grace to you if you feel a little bit hesitant about reaching out because you don't have people that look like you.
Right.
We're also saying that your child is still worth it. And if you cannot find a Black ophthalmologist or optometrist, we still encourage you to seek medical help because your child deserves it. You are your child's best advocate. You deserve and you're able to shop around. You do not have to be stuck with a professional that doesn't listen to your needs. But we do extend that grace and recognize the gap in this field, which makes me appreciate both of your work even more if I didn't say that already. So thank you for how you show up. But also working in a rural area, Dr. Ibaronke, also can't imagine because there are a lot of disparities, not just in terms of like the workforce, but in terms of resources. How do people get to follow-up appointments? Can they take time off? Can they afford these things? These are all things that we have to think about when thinking about solutions and how to have these conversations. So I appreciate you both for pointing that out. But also in terms of disparities in all things visual in our communities or in African American communities, what about vision conditions? Are there disparities in the way certain conditions show up in our community?
A study that I was part of at Johns Hopkins did show that some kids could have a little bit more of an eye turn compared to our Caucasian kids. That being said, though, it's the pool that we also looked at. We were able to put the data together from the West Coast and the East Coast. We didn't look at the flyover states, so maybe it's specific to the West Coast and East Coast. So I can't generalize it to the entire country. But we have to kind of be mindful of that. Like, hey, some of these kids could actually have eye turns more than other children. And of course, those eye turns, when they come to me, and if I can't do anything else, they're going to go to Dr. Arthur and be like, hey, can you take care of this kid and make the eyes line up a little bit better?
So an eye turn is when that eye most literally turns, or it's not totally aligned.
That's correct.
Exactly.
Any other visual conditions? I've heard of cataracts and glaucoma maybe being higher in the African American community. Is that what you all see with even children that are Black, or is that something that usually develops further along?
It's not impossible to have those conditions in the pediatric population, but they're fairly rare. When I've seen them mostly in children of color, but I also work in Brooklyn, which has been, historically had a very large Black and brown population. There are certain medical problems that could predispose you to having eye problems. So if you have sickle cell disease, if you have things like cerebral palsy, Down syndrome, hydrocephalus, which is fluid around the brain, any sort of neurological things that impact brain development can also affect the eye also. Prematurity, these are all things that impact significantly Black and brown communities that can also show up in terms of the eye.
Interesting. So we were talking about pediatrics and eye care early on for those of you who just joined. And I want to recognize our audience and thank you so much for engaging. Jeanette in Oxford, North Carolina, we see you. I see Karen is a patient of Dr. Arthur. She wanted to point out that you do not only treat children, you also treat adults, and you've treated her for decades. That is a very profound relationship. And the fact that you kept coming back, I think, says a lot about Dr. Arthur and her practice. So awesome. Thank you for your impact. Charles from Austin, Texas. Laya, we see you. Loretta from LA. We also see you. And Janet from Hot Springs, Arkansas. Janice, thank you so much for joining. Again, this is a conversation. If you have questions, we will try to get to them. So feel free to post them in the chat. In the meantime, we are monitoring the chat. Let us know where you're tuning in from. And thank you so much for joining tonight's discussion. Also share this with your family and friends because the main point of this is resources and access to information. So let us know who can benefit from this. Hey, Carol, thank you so much for joining. Okay, doctors, we're talking about these comprehensive eye exams and how beneficial they can be. When is the best time for children to start having routine eye exams? And can you tell us a little bit about what happens during an eye exam?
Sure, I can take that. So according to the American Optometric Association, they say kids, actually babies between 6 and 12 months should have their eyes examined first. That's the first time. And then when they become 3 years old, 5 years old, and then at 6 years old and every year afterwards in school. And of course, we have different associations here, so there are variations on that. However, I want to submit to the audience, if you're looking at your child and they're not 3 yet, but they're 2, and you think that something is wrong and you're noticing an eye turn, or you think they're running into things and they're not coordinated or their visual attention is not good, don't wait until those defined times to go get care, because that could mean that the kid is starting to show something and they're telling you that they can't see. So don't wait till those defined times. But those are some of the times that we have outlined for the American Optometric Association.
Yeah, the ophthalmology communities are slightly different. We usually recommend in children a preschool eye exam, which, preschool usually is around age 3 or 4, because you have a kid now who's verbal, can read maybe pictures on the chart, might be more cooperative and be able to engage. But just to echo what Dr. Ibrianke said, if there's any issue that you're concerned about with your child, it could be an infant, you should bring that child to someone's attention. So sometimes I'm seeing infants who are a few weeks old or a few months old because someone has noticed something that just doesn't seem right. And sometimes they're very young and it's something that you just have to follow up on. But we want those kids brought to our attention, because the sooner we find any issues, the easier it is for us to treat. Um, Very often what I find is most kids are not going to complain. You could have probably a very significant visual problem in a kid and they probably won't complain. When they hit usually the 4th or 5th grade, either a teacher's going to pick up on something or they may say something, but kids are extremely stoic and will sometimes be suffering and really won't complain. But usually we're saying preschool, and then I really rely on the primary care providers to do that initial screening, because if I saw every kid who wanted to have a comprehensive eye exam every year, I'd be living in this office. I wouldn't be able to leave this office. So we count on a lot of other providers to do that initial screening and then decide, does this person need to be seen by, an ophthalmologist?
I appreciate what you pointed out about kids, because again, it reminds me of my childhood and how I just sat myself in the front of the class because I couldn't see. I wasn't telling my parents that I was having issues. You just adjust and you normalize so many things. Children are so adaptable. So
Exactly.
can we go over really quickly again, Dr. Ibironke, some of the things to look out for early on so that we don't have to wait for those benchmarks if we're concerned? So I know you said an eye turn, which is like when your eye is not totally aligned. Anything
Yep.
else that they can look out for?
So the appearance, so we can talk appearance now. And I think Dr. Arthur is going to go into this a little bit more later, but the appearance of the child, are their eyes tearing all the time? Is a lid swollen? Does it look like a lid is drooping? And then their behavior, does it look like they're rubbing all the time? Are they running into things? And then complaints. So there are some kids, they're not going to complain ever. And there are some kids that'll tell you, hey, that's my bad eye. They'll actually tell you, like, hey, that's the eye I see out of. And when they cover, I can tell that's my bad eye. So those are some of the things and concerns. So it's like the ABCs: appearance, behavior, and complaints.
Great. Appearance, behavior, complaints. That's really good acronym. Are children at higher risk of vision conditions, Dr. Arthur? And what systemic or familial conditions warrant evaluation by a pediatric eye doctor?
Well, once again, if you have children with certain systemic diseases, juvenile diabetes, which one would come to mind. We've had a big increase in kids who are now becoming type 1 diabetics, and they should be checked to make sure they're not developing any problems with their retina. Children who are sickle cell, particularly sickle SC disease, definitely by the time they're 10, should be having a fully dilated eye exam. I see a lot of those kids even before 10, looking for, abnormal blood vessels inside the eye. They can also develop bleeding inside the eye or traction retinal detachments. Juvenile kids with juvenile rheumatoid arthritis. Once again, these are not totally very common diseases, but I do see children with these diseases being in New York City, and they deserve to have a thorough eye exam looking for any secondary inflammation of the eye that can occur. Children who are premature are at risk to develop lots of problems with either strabismus, which is the misalignment of the eyes, amblyopia, which is when vision doesn't develop correctly in the eye, or even having refractive disorders, needing glasses, being very nearsighted or very farsighted, or having lots of astigmatism. So if you have a kid who's really premature, not 38 weeks. 38 weeks is a fully grown. It was 2 weeks early, but that's not what we consider prematurity. We're thinking if you've had the baby 28 weeks or less, those are the ones that really have high risk for having lifelong complications potentially with their eyes. I'd like to make a special plug for special needs children. So if you have a child who's on the spectrum or a child who's not verbal, or is having some learning difficulties. I think these are kids in particular who sometimes are overlooked. And I think in the pediatric ophthalmology as well as pediatric optometric community, we make space for those children who people may consider to be difficult, because we can figure out what's going on with them and sometimes really help and assist that family if this kid has a visual problem, even if this kid is a kid who's not talking, not speaking, not reading the chart. I mean, I remember the first time I explained to someone that, yeah, I can tell you if your baby needs glasses and give you the prescription. And they were like, how? And I was like, watch. And so those are the things I think in terms of systemic issues or familial issues. Obviously, if you have a family history, sometimes I have people come in and say, every male in my family was born with cataracts. Well, now we're watching all those babies that come out because there's something genetic going on, right? But in particular, we're looking once again for people who have certain sort of immune conditions, like I said, rheumatoid arthritis, sarcoidosis, lupus. I'm seeing lots of kids with lupus now. Any sort of neurological situations that's going on. If you have a kid with a known tumor, brain tumors, we see kids who are on chemotherapy and having side effects from chemotherapy that affect their eye. So any of those things should warrant, an evaluation.
So I heard you talk about all the men in my family having cataracts, and there may be a male child now that you're watching out for. So just for the audience's sake, are some of these vision conditions hereditary then?
Some of them can be hereditary, absolutely. And once again, those parents are usually self-presenting. I mean, folks who have a problem and know, like, all the girls in my family had this issue, all the boys in my family had this issue, they self-present. Every once in a while, though, I get a kid who just has a cataract, hasn't had trauma, may have had it from birth, maybe it changed. And cataracts in children are a lot different from cataracts in adults. If you develop a cataract as an adult, we take that cataract out, we put a lens implant in, and you see 20/20, 99% of the time. In children, anything that interrupts them from using the two eyes together, anything that makes them not use binocular vision, can cause permanent vision loss. So if you're an infant and you have a cataract, that cataract usually has to come out pretty promptly. And even in those cases, sometimes the prognosis, even with visual rehabilitation, is not that great. Because the eye is really part of the nervous system, the central nervous system, part of the brain. So anything that interrupts that development usually causes some degree of permanent damage in infancy.
Oh, because their brain is still developing.
Exactly.
Oh, so fascinating. So, but still, time is of the essence, and this is why we have to be prompt with these things, which is
Absolutely.
why the earlier you catch it, the better your outcomes, typically. Dr. Ibironke, we hear 20/20 vision, but what exactly does that mean? And how does this describe how a child sees?
So that's a really good question because everybody knows 20/20. You hear it all the time. So it actually means the visual acuity. So it means how the clarity, how clear the vision is. So let's try to explain it. So when we say 20/20, that means what Johnny is seeing at 20 feet is also somebody that has good vision is also seeing at 20 feet. So that's great. So good vision and Johnny, they're both at the same level. But if we say Johnny has 20/50 vision, that means what Johnny is seeing at 20 feet, the other person with good vision can stand at 50 feet and see what Johnny has to stand at 20 feet to see. So Johnny is closer. So that's not good because Johnny has to be closer to what he has to see. So as the bottom number, the denominator is getting bigger, the worse the vision is because a better person with better vision can stand further and further back, but they're closer to what they have to look at. That's the definition of visual acuity.
Interesting. So 20/50 means it takes a person, is it literally feet or is it just
feet?
Oh, so then it must be, is this an American metric? Because I know around the world they use like meters and all these other.
That's correct. So we can just convert it. So we can
Okay.
convert it to 6 meters.
Okay.
We can do 6/6. Yeah.
My personal question, in Europe, do they say 20/20?
I think they go 6/6.
I
Like
think it's 6 over
they
6.
do meters.
Oh. See, we're all learning tonight. That's very not on the script. So that's how you know Dr. Ibironke and Dr. Arthur both know their stuff. Thank you for that. Math is pretty intimidating a lawyer, so I'm very impressed that you were able to do that conversion so quickly. But thank you for clarifying 20/20. This also then applies to how children see, correct? You weren't just talking about adults. Okay, great. Can you also talk, Dr. Ibironke, about nearsightedness, farsightedness, and like what I mentioned, astigmatism?
Sure. So nearsightedness means that a child's able to see up close, but when they look up to look at a distance, they can't. So it's fuzzy at a distance. That's nearsightedness. Farsightedness means at near, they're at near they have issues, but at distance they're okay. So that's farsightedness. Astigmatism, that means that instead of the eyeball being shaped like a sphere, there's actually a curvature to it. So it looks more like a football. So there's a longer side to it, the football, and a shorter side. So when that curvature is really pronounced, it's no longer a sphere. And when light hits the eye and when it focuses at the back of the eye, it's kind of smeared up a little bit. So a cursive A could look like an O, a cursive F could look like a T. So things are kind of smeared up. And of course, this is going to affect learning and reading. So those are those definitions.
And can an eye develop astigmatism? Let's say you weren't born with it, but you had nearsightedness. Can later on you develop astigmatism, or is that kind of like a stagnant thing where it's either you have it or you're not going to have it?
So there could be a little bit of it, but it's not going to be pronounced. Like if you only had like half a unit of it, you're not going to now develop 3.5 units of it later. You see what I mean? It's not going to change. However, if there's pathology, so right, Dr. Arthur, if we have something like a ptosis where a lid is on the eye and we don't fix that in time, so that's that critical period, that could actually induce astigmatism now because we didn't fix the eyelid. And now we have two things on our hand. We have the lid that's coming down, an eye that doesn't see well, and astigmatism in the way. So that's why we have to take care of that. So astigmatism can develop in that kind of scenario.
Yeah, absolutely.
Another push again for early intervention and regular screenings at a young age. So, Dr. Arthur, what are some warning signs? We talked about this of possible vision problems. So, an eye that's kind of askew,
Right.
children that are bumping into things. I was also thinking about behavioral issues at school with children.
Well, I would say the big thing that we look for is strabismus, which is a misalignment of the eyes, which is fairly common. We see that in about 4% of the population. And that's important because once again, if the two eyes are not working together, you can start to lose vision in one or both of the eyes. We're looking for things like squinting. Sometimes when a child has a misalignment, some kids will close one eye or cover one eye or even tilt their head a certain way when they try to focus on something, because when the eyes are misaligned, the eyes are focusing on different parts of the retina. So they're getting a double image, what we call diplopia. So in order to relieve that double image, kids will sometimes walk around and cover one eye or tilt their head. One of my favorite stories is a kid came to see me because someone was sitting behind him in church, and the kid had his head tilted all the way to the side, about 45 degrees. And someone tapped the mother on the shoulder and said, "Your kid needs an eye exam." And the kid ended up having a muscle paralysis that we were able to correct. And he was able to hold his head straight. But he was compensating for the fact that he had this vertical imbalance between the two eyes. One eye was higher than the other. So we're looking for things that, once again, is in terms of behavioral issues. Kids, I think that I see tend to be somewhat either disinterested or struggling in school if they have a visual problem. And a lot of the times when people are concerned about academic performance, one of the first things they want to do is check the eyes and make sure that that's okay. And I've had parents come back and say, I think that was the problem because now, Johnny or Mary they're totally performing, they're paying attention, they're engaged. So those are the big things. Once again, I want to emphasize that kids are not complainers. I mean, they really, really aren't complaining. So it really kind of behooves those of us who are mothers and fathers and grandparents and teachers and school nurses and pediatricians to really be looking for these signs. I've seen kids tolerate all sorts of things, foreign bodies in their eyes, traumatic, lacerations that were probably going on for, days, if not weeks, because they weren't going to complain. And by the time they did complain, they had a big problem.
Wow. I can definitely relate to the squinting and the one eye, but yes, look out for some affects in your children and the way that they're kind of presenting themselves, especially when they have to do visual activities or see things. Dr. Arthur, are there other eye problems that can affect children? For example, what is, and you might have to correct me, amblyopia or lazy eye? And what are the 3 different types of lazy eye?
Okay. So amblyopia is a condition where children don't develop normal vision. And it can be caused by a couple of things. It can be caused by the actual misalignment. So sometimes the eye's misaligned and the child will start to, once again, not use that eye and lose vision. So if your eye started crossing today, you'd have terrible double vision, but you wouldn't lose your vision. In children, if they're below the age of 9, because once again, their visual system hasn't matured, they can actually lose vision in the eye that's turning. The other type of amblyopia happens if what we call deprivation amblyopia, meaning there's something that's organically wrong with the eye. Maybe the child has glaucoma, maybe there's a cataract, maybe there's something blocking the vision from entering the eye. And so once again, if they can't use the eye, their brain shuts off the information from that eye, they lose vision in that sense, right? You can also have what's called refractive amblyopia. You have an eye that maybe is really nearsighted and the other one isn't. So the kid goes, I'm going to use the one that's good, and I'm not going to use that other one. I'm not going to worry about that. So once again, they're not able to use the eyes together, and so they start suppressing information from one of the eyes. The good news is that it's treatable, but you want to catch most of these cases before they turn 9. And that is the key thing in terms of the eye development, is that age of where you have that critical development usually stops at age 9.
Interesting. Age 9 is when we really want to make sure that we have these.
By age 9, the earlier the better.
Yeah.
Got it. And you had to help me with another word, Dr. Arthur. What is strabismus?
Strabismus. Okay, strabismus is what most of us as lay people will call cross eyes. So you can have an eye that turns in towards your nose. You can have an eye that drifts out towards your ear. You can even have one eye that sits higher or lower than the other eye. Okay. And the key thing about strabismus is that the first 2, 3, 4 months of life, kids' eyes can do lots of different things. We're not too worried. But after really 4 or 5 months of age, the eyes should be straight. If the eyes are misaligned, you're likely to have a visual problem that's going to occur. So strabismus in the kids who are below the age of 9, I sort of tell patients that's more like an emergency. I'm really concerned something's going to happen. After the age of 9, I'm more concerned about social interactions. Are people noticing that the eye's turning? Do they feel funny? Are they being bullied? Are they having any double vision? But they're not going to lose their vision. But below the age of 9, it's a vision-threatening condition.
Interesting. And are there treatments?
Absolutely. It can be treated in a number of ways, both of these conditions. The first thing we want to make sure is, does this kid have a refractive error that could be causing this? Sometimes kids are very farsighted, as Dr. Ibrianke pointed out, having problems seeing at near. Some of those kids will have eyes that turn in, because as they try to focus, it stimulates convergence. So sometimes a pair of glasses will fix the crossing as well as the vision problem. Some kids, if they've lost vision, would benefit from wearing an eye patch. for several hours a day. There are certain glasses called prisms that sometimes can be helpful for some of these conditions. And some patients do need surgery. And so sometimes surgery ends up being an option.
Thank you for that. I want to get to a consideration from the audience. I know it's been on my heart in this day and age of technology. We have a few minutes left, but I think this is one is really important. Dr. Ibironke, here's a question that I know the audience is considering. Can the use of smart devices affect children's developing vision? And if so, what are recommendations that you may have?
And it could. It could. It can cause their nearsightedness to become more nearsighted. There's some studies that are starting to show that. It can cause discomfort because now they're looking at their device and they're not blinking their eyes. So it can cause their eyes to dry, discomfort, redness. They may be rubbing their eyes. So some recommendations would be after playing on that video game or something, take a break. After playing for about 20 minutes, take a break. Look about 20 feet away for about 20 seconds and blink your eyes 20 times. So they call it the 20, 20, 20. And then there's a 2. They add a 2 to that. And you should be playing outside for about 2 hours so that you're not constantly here. And then, of course, our kids walk around with their devices, maybe having a bigger device, not just a smartphone, maybe their iPad or the computer, or having them project whatever they're looking at on the TV will be better.
I was an avid reader growing up, and I would read with my books right here. Can the same concern translate to reading, not just smart devices?
So, and we want our kids to read, however, still taking those breaks. And then also teaching your kid about good reading habits, making sure that the lighting is on, making sure you're not holding it too close. So probably about 40 centimeters away, 30 to 40 centimeters away from them is a good place to have the reading material, but not too close, because if it's too close, it could induce that nearsightedness. Go play outside for 2 hours.
Interesting. If only I knew. I got to show this to my parents. Okay, we have a few more minutes left. Dr. Ann, Dr. Ibironke, if there is one thing you can leave audience members with, grandparents, caretakers, parents, what would it be when it comes to pediatric eye care and eye health? Dr. Arthur, we'll start with you.
I would say to trust your gut. I would say that most of the very serious things I've picked up in almost 30 years of practice have been picked up by parents and caregivers. And I always tell parents, if I see a kid in my office, if I didn't find anything, I say, if you still think you see a problem, your kid's been with me for 20 minutes or 30 minutes, you're with this kid 7 days a week, 24 hours a day. If you think I missed something or something is happening, come back. Because I'm seeing a slice of your kid probably in the morning. They're not tired. There's no other factors happening. And I will say that parents are incredible screeners, parents and grandparents. Most of the very serious conditions that I pick up are usually self-referred by the parent or guardian. So trust your gut. If you see something that you're not happy with, get an opinion. If you're not happy with that opinion, get a second opinion.
Awesome. Trust your gut. Dr. Ibironke.
And I second that all the time. Like, I'll even tell the parent, hey, just because I'm not seeing it right now doesn't mean it doesn't happen and you don't see it. So that's my language. That means, so I'll set even the follow-up. I'll set it up and say, come back in 6 months or whatever the appropriate follow-up is. So my point to leave with people is the earlier the better. If your kid does fail a screening, get them to an eye doctor to get the follow-up and proper treatment.
Awesome. Trust your gut, and the earlier, the better. We hope you are empowered, enlightened, informed, and encouraged. Share this with your community, share this with your family and friends, and with yourself. Thank you both so much for all of your wealth of knowledge. I definitely was encouraged and educated tonight, and I appreciate your expertise, your commitment to community, and all of your time. Thank you both.
Thank you for having us.
And thank you for watching. That's all we have, folks. Join in tomorrow for tomorrow's segment. Take care.
Good night.